All right, good morning, everyone. I'm very happy to be here on this day. Thanks to Dr. Vitale, Dr. Kessel for arranging this conference for us. So my talk this morning is on partial joint replacement. When does it work? Partial joint replacement is often also referred to as unicompartmental knee arthroplasty, or UNIs. This is the agenda for my talk this morning. And we'll begin with a case. So a 60-year-old man presents in clinic with knee pain. He has extended duration of symptoms, as well as large severity as well. He localizes the pain entirely to the medial aspect of the knee or the inside of the knee, and has limitations with daily activities, including walking, prolonged standing, etc. And he's really tried everything. So he's tried anti-inflammatory medications, steroid injections, as well as physical therapy. And despite all this, he's continued to have significant functional detriment for his quality of life. These are some representative x-rays. So to orient you, on the left-hand side of the screen is an AP radiograph. On the right side of the screen is a lateral radiograph. And these show medial joint space narrowing. You can tell that by the relative narrowing of the radiolucent or empty appearing space in between the femur bone, which is up top, and the tibia bone, which is down below. And that's also redemonstrated on the right-hand side on the lateral x-ray. So what are the options for this patient? And ultimately what we're asking is, what is the best treatment for symptomatic severe osteoarthritis of the knee? And on the left-hand side, you can see diagrammatically what that looks like in the picture. So osteoarthritis essentially is characterized by thinning of the cartilage, leading to full thickness cartilage loss, joint space narrowing, and that leads to increased pressure on the bone essentially, and for most patients that leads to significant pain. As a secondary consequence, you can have formation of bone spurs, which are also known as osteophytes. Secondarily, that can lead to things like stiffness as well as crepitus, which is the sense of popping or catching in the joint. To the right, you can see what that looks like macroscopically. So the top right-hand part of the screen shows smooth, normal, articular cartilage, and to the bottom, you can see full thickness cartilage loss, inflammation, and lack of normal sphericity of the joint. So how do we treat this? So even surgeons always start with non-operative treatment. This begins with things like medications, which are anti-inflammatory medications typically, physical therapy, wellness and weight loss, which are very effective, and then potentially injections, which could be steroid or viscosupplementation, which are also known as gel injections. For patients who try all these therapies and continue to have functional limitations for the quality of life, we then begin to talk about surgical treatment. And for the treatment of severe osteoarthritis of the knee, there are really two, which are partial joint replacement, again, unicompartmental knee arthroplasty, and total knee replacement. So one thing that's important to note is actually that partial joint replacement is not new. It actually has its origins in the 1950s and mirrors the rise of total knee arthroplasty, in fact. If you look at the ad to the right of the screen touting the quote-unquote conservative approach to total knee replacement, this looks like an ad you can see nowadays on a billboard potentially or in a medical journal. Unfortunately, these early implants were plagued by a high risk of revision, which means that these patients had a relatively short period of time between their partial joint replacements, or UNIs, and conversion to a total knee arthroplasty. And this was likely multifactorial, probably some issues from the implant design, the way that the plastic was treated and created, some surgeon or technique-related factors, and then patient selection. We've really seen a rise in the interest from both patients and surgeons in partial joint replacements over the past 10-15 years, and this is due to several factors as well. One is that there have been some incremental improvements to the prosthesis design. Number one, the fixation methods for the implants to the bone has improved, which decreased the risk of loosening of the implant. We've improved the way that we process the polyethylene, which is that white plastic insert you can see in between the two metallic implants. And then we were better at patient selection. So we're choosing to do this surgery on patients that really have more limited arthritis rather than more diffuse arthritis in the knee. And between all this, recent studies do show that there is improved survivorship of these implants. This is coupled with a growing change on the part of patients looking for relatively minimally invasive surgery to get back to their quality of life. So overall, total joint arthroplasty patients are younger and more active than they were historically. And here you can see right off the bat why this can be an attractive option for a younger, potentially, or active patient. So on the left-hand side are plain films, AP and lateral, of a partial joint replacement. On the right are plain films of a total knee replacement from the same manufacturer. And you can tell during the surgery, just looking at the x-ray, the surgeon can access a smaller part of the joint, the incision can be smaller, there's less trauma and dissection of the soft tissues, and all of that can lead to decreased pain on behalf of the patient. And this is what those implants look like in real life. So on the left-hand side, it's a partial joint replacement, and you can see it essentially looks like half of the total joint replacement that you see on the right-hand side. And again, to put that smaller implant in is typically a smaller incision, smaller dissection, and less pain for the patient. Indications. So very importantly, patients who are indicated for partial joint replacement should really only have severe osteoarthritis in one part of the knee. So we say that's unicondylar, which is a limited knee arthritis. These patients should also have either functional or anatomic integrity of the ACL and intact peripheral ligaments. Some areas of controversy include age and BMI. Those are also areas of controversy in total knee arthroplasty. Specific to partial joints are deformity, so we think that these patients should have relatively minimal deformity, which would be a flexion deformity, which you can see in patients with severe osteoarthritis, and they should have functionally intact ACL. And there are some real benefits of partial joint replacement or unis. So one, as I mentioned before, clearly these patients have reduced morbidity, and these are often successfully done in the outpatient setting. There's less pain compared to total knee arthroplasty, faster recovery. As we leave the cruciate ligaments intact, as well as the rest of the joint, these patients typically have improved kinematics of the knee, so the knee feels more normal, and as a result, they're able to go back to their daily activities and have a higher level of function, relatively speaking. This was a patient I met in my training who actually had hiked the Appalachian Trail only 3 months after his partial joint replacement surgery. And if you're in the office, in the community, or in the physical therapy office, you can see these patients with partial joint replacements. Many of them are doing very well and very happy with their overall result. So what's the catch here? So this is really the main problem. Partial joint replacements across many studies have a shorter lifespan when compared to total knee arthroplasty, and that is consistently demonstrated in the literature. And this is for two reasons. One is loosening of the implant, although that is shared in common also with total knee arthroplasty. Specific to partial joint replacement is the fact that you will at some point have progression of osteoarthritis in most patients to the remaining parts of the knee. The Australian National Joint Registry is the largest registry looking at this, and they showed suboptimal outcomes of partial joint replacements compared to total knee, 80% survivorship at 15 years. This is a recent meta-analysis looking at several large national joint registries and also several large cohort studies, which showed slightly different data. But again, when you compare total knee arthroplasty, so that's TKA, and partial joint replacement, across the board at every time point, these patients have a higher risk for failure and need for re-revision or revision surgery. When you take a closer look at this data, you can tell off the bat that the joint registry data shows that the outcomes are poorer compared to the cohort studies, and that's likely due to surgeon experience. So potentially, with a high volume surgeon with training doing partial joint replacements, potentially the outcomes are better. Some more controversy. So if you have a partial joint replacement, it fails, and you have a total knee replacement, do those patients do as well as those who had a primary joint off the bat? And generally, the answer is no. So these patients generally do poorer, with poorer functional outcomes and higher risk for subsequent surgery even after that. And so this leads to criticism of the use of partial joint replacement or unis as a bridge treatment. For patients who are younger, more active, potentially have a higher BMI, does this lead to a shorter lifespan for the implant? And most likely it is, although the data is inconsistent on that point. And then last, what is the cost ramification of doing partial joint replacements and the risk of conversion to total knee arthroplasty? So one thing is clear, which is that doing a partial joint replacement off the bat represents a significant cost savings to the healthcare system compared to doing total knee arthroplasty. That's in regards to many factors, one of which is decreased need for rehab after the surgery. What is unknown are the long-term consequences of this. So if there's a higher risk for revision surgery in the partial joint replacement category, what is the cost associated with the second surgery? And this is often associated with higher utilization for rehabilitation and then higher risk for complications. So bringing it all back to this patient, This is a 60-year-old man who had isolated medial arthritis in the knee, no deformity or flexion contracture, and a functionally intact ACL. So this would be a patient that you could talk about being a candidate for a partial joint replacement. In fact, this would be a patient that may do fantastically well with a partial joint replacement, but it's very important to have informed consent and have that discussion with this patient regarding the risks of failure down the line. So in conclusion, partial joint replacement or unis can be a very good option in patients with isolated knee arthritis. Informed consent is really critical. So for all these patients that come to the office, the surgeon has to have a conversation with the patient regarding the risk for repeat surgeries, weighed against the faster recovery and the improved kinematics of a partial joint. The surgeons have to manage patient expectations, so even a partial joint replacement won't make the knee bionic. It will make the patient more active than before typically. Again, this is also a pain-relieving procedure. And then last, on a public health standpoint, we know that the burden of knee revision surgery is increasing exponentially. Who will be performing these revision surgeries? Many surgeons who do knee replacements don't do revisions, and so finding the surgeons and specialists who can handle these will be an issue on a population health basis at some point. And last, what is more cost effective to the healthcare system long term? Thank you.